Our next speaker is Dr. Robert Kidd. He is a graduate of McGill University and has practiced emergency medicine for 10 years. He has a medical consulting practice in Renfrew, Ontario for almost 40 years. His practice integrates osteopathy, neural therapy, nutrition, toxicology, psychosomatics, and energetics. He has a special interest in the interplay between osteopathy, neural therapy, and dentistry. Dr. Kidd has published extensively in peer-reviewed literature and has written a textbook of neural therapy called Neural Therapy, Applied Neurophysiology, and Other Topics. And he writes monthly neural therapy e-newsletters for physicians and dentists. For over 30 years, Dr. Kidd has lectured at many conferences on a variety of topics in Canada, the US, Europe, Australia, and South America. He was the first president of the American Association of Orthopedic Medicine. He is a past president of the American Association of Orthopedic Medicine and past vice president of the North American Academy of Musculoskeletal Medicine. He is also past president of the North American Academy of Neural Therapy and has served in numerous positions for other medical educational organizations. Please join me in welcoming Dr. Robert Kidd.
Thank you. Good afternoon, and thank you, organizing committee, and Rick Fisher for bringing me back. It's a great honor to be invited to speak here. It's even greater honor to be invited a second time. And I really enjoy being here. I enjoy the people who are here. And I must say, this meeting has had some excellent lectures. I think one of the things that I always look for in a lecture is to have one little thing to bring home. And every one of the lectures I've heard since yesterday morning has offered that and more. So the topic is medical-dental-osteopathic connections. And when I first discussed this with Rick Fisher, I had the idea of doing a kind of a survey talk to cover this broad area. But the more I thought about it, the more I realized that might be boring. And so rather than trying to cover all the territory, what I'm going to do is try to just pick out a few things in a series of areas that might give us an idea of the gist of where we're going, but also have some take-home stuff and maybe a few things that you might even want to incorporate into your practices. So before starting that, let's talk about medical-dental-osteopathic connections. What do these words mean? Now, they can mean lots of things, but in this lecture, when I use the word medical, I'm referring to the realm of medicine that most physicians either do or could or should be doing, such as nutrition, toxicology, immunology, and neurology. Of course, there's many other things, but I think in the context of what we're talking about here, those are the kind of areas that physicians might contribute something to the discussion. Dental realm, I'm just arbitrarily saying it's going to be about dental and prosthetic anatomy, dental infections, energetics, I'm just going to briefly connect with that, and oral mechanics. And in the realm of osteopathy, really what we're talking about is the musculoskeletal part of this whole picture. Obviously, in the US, osteopathic physicians, they do a lot of general medicine, but here we're going to talk about the core of osteopathy, that relationship between the musculoskeletal system, neurology, and general health. So, overall, these are the areas that I want to cover, or at least little bits of these areas. The first being medical impacts on oral health. In other words, how the systemic aspects of our being affect our oral health. Then the opposite, the dental impacts on systemic health. And thirdly, the osteopathic or musculoskeletal impacts on oral health, and the dental impacts on musculoskeletal health. Now, to be complete, there should be a medical-osteopathic connection, but I'm not going to do that today. So let's talk about some of the areas that medicine affects oral health. And I'm going to indulge myself here a little bit to give you a little bit of history. This is a picture of where I went in my last year of medical school, 1969-70. That spot up on the top of the map is Pangnirtung, a little Eskimo settlement. At that time, about 700 Eskimos. And previously, there'd just been a Hudson Bay trading post and a little nursing hospital center. And in the previous 10 years, the Canadian government had been trying to invite Eskimos to give up their nomadic life, which was traveling around little bands of 40 people, eating nothing but seal meat, Arctic char, caribou. And over a period of 10 years, these people settled in Pangnirtung. It was a gradual thing. And they were then introduced to what the Hudson Bay store had to offer, which was Pepsi Cola and white flour and sugar of all kinds. Now, before I went there, I was warned that I needed to know a bit of dentistry. So I had a half-hour crash course in pulling teeth. And when I got there, the nurses, there were 3 little British trained nurses, they were happy to have a nice strong 20-year-old to pull teeth. So that was one of my first tasks. And I guess I was good enough at it that after the first couple of teeth I pulled, there was a lineup of people wanting their teeth pulled. And so I had a good look in people's mouths, and didn't take long before I realized there was a big gradation in the health. And it was in a short while I was able to estimate how long those people had been living in Pangnirtung. If they'd been there a couple of years, there were a few cavities. If they were there 4 years, there was cavity really going. By the time 10 years, their teeth were rotten. So that, I didn't realize this would play a role in my future practice of medicine, but it did. And I'm going to now just pay homage to some of the great nutritionists of the 20th century. And most of them were dentists. In fact, this whole list, they're all dentists. Now, the first one would be Weston Price. I imagine most of you know about him. Melvin Page, Royal Lee, Harold Crystal, William Kelly. And I'm just going to say a few words about each of them, not very much, but just to give them some recognition for their contributions. The great one was Weston Price, who made contributions in 3 areas. One was the nutritional effects on body structure. In particular, what a degenerate diet does to the mouth and the general health of people who eat industrial Western high sugar, high flour foods. Second area was in the area of dental infection and how it affects systemic health. And the third was his discovery of something that he called Activator X. And he described very clearly what that was, but only in the last 15, 20 years did we discover that that was what we now call vitamin K2. I'll say a few more words about that in a minute. Now, I'm going to indulge myself again a little bit to make a personal connection with Weston Price. He was long gone before I appeared on the scene, but you'll see from the map, at the top of the map is a place called Renfrew, and my wife Wendy and I live just a few miles away from there. The bottom of the map is Newburgh. That's a little hamlet of 600-700 people with a church, and that's where Weston Price was born. This, by the way, is about 5 hours drive west of here, so not too far from Stowe, Vermont. I had actually heard about Weston Price. Some of the old timers had told me that this Weston Price, this famous dentist, had a practice on a little village halfway between those two spots. It's not even on the map. And I pursued that, and it was hard to believe because there's not even a hamlet on that lake. But it turned out that when he succeeded as a dentist in Cleveland, Ohio, he used to come back there in the summers. And eventually he had a cottage there, and then he had a little lodge. He and his wife had a lodge, which they operated for about 10 or 15 years. So that's my connection with Weston Price. Melvin Page followed in Weston Price's footsteps, and he studied calcium and phosphorus, which Weston Price had identified as being critical to dental health and general health. But Weston Price went and started measuring it in tens of thousands of patients. And what he discovered, correlating calcium-phosphorus ratios with dental health, was that a low calcium-phosphorus ratio went with dental infection. And a high calcium-phosphorus ratio goes with gum disease. But not only that, these off-balances in ratio went with the autonomic nervous system. So people who have low calcium-phosphorus ratios tend to be sympathetic dominant, and those with high calcium-phosphorus ratios tend to be parasympathetic dominant. Now, we're going to come back to that subject a little later. Royal Lee, does everybody know about Royal Lee here? If you might, I guess. He was a true genius because he had 3 careers. He was a dentist. He was also a brilliant engineer. He invented lots of important things in the electronic industry and in military. He had 100 patents. But his great love was nutrition. And he broke with the pack by pointing out that these vitamins and minerals that we're finding in food, they're important, but it's important that they're with food. And he felt that isolating vitamins and minerals, you were dealing with a different substance than the substance that is in food. So he developed a method of desiccating foods and compressing them and providing nutritional products that would correct all kinds of medical problems. He's gone, but the company that he founded is Standard Process. Do anybody of you know about Standard Process? It's quite a different way of doing nutrition, but really an excellent way. Harold Crystal, his interest was nutrition and how nutrition affects different people differently. And he did many experiments. He had a clinic where people would come in, have a test meal in the morning, and he would measure their saliva, urine, and blood over the day to see how the pH and other things responded to the diet. And what he learned was that if we want to make just a classification of the population in 2 halves, 1 half of the population are fast oxidizers. These are people who need food on time. They need rich food. They like red meat and oily fish and things like that. Slow oxidizers, they are grazers. They can fast. They don't care if lunch is late. They do well nibbling on lighter foods. They tolerate grains reasonably well. fast oxidizer do not. So when I see people who try an Atkins diet and it's killing them, I can tell them, well, you know, that's your metabolic type. That's maybe not best for you. And other people who are struggling with they want to be real healthy and have a vegan diet and it's killing them, I tell them, well, you're not that metabolic type. William Kelly, he learned nutrition the hard way by developing a very serious cancer when he was a young man. And he survived it with the help of nutrition. And he went on to treat other people quite successfully, got in a lot of trouble with the cancer authorities because of that. And he also recognized this correlation between diet and the autonomic nervous system and types. He showed that people who developed hard cancers tended to be type A personalities. By hard cancers, we mean breast, stomach, prostate, and so on. Whereas the laid-back, parasympathetic dominant people, they would get the soft cancers, lymphomas, leukemias, and that sort of thing. And these people, they did better on the rich, oily, high-protein diets. The people with the hard cancers did better on the vegetarian diets. Now, most of us are somewhere between those two extremes, but it's something, again, to remember that there's no diet that fits everyone. I just mentioned this book because there's a really excellent coverage of this whole thing by Nicholas Gonzalez, who sadly died just a couple of years ago, but he followed up on William Kelly's work and also the Pottinger Jr. and Sr. Now we'll come back briefly to Weston Price again. These are, at a later stage in his life, he went around the world studying people who had, you might say, Paleolithic or primitive diets with no refined foods and no sugars. And what he found, he went to places like South Pacific, Canadian Arctic, the Scottish Outer Hebrides, the top of the mountains in Switzerland. And what he found was these people who had these primitive diets, they had beautiful teeth, beautiful facial configuration, no crowding of their teeth, excellent health in many ways. Now, when they started eating the modern industrial diet, the first generation more or less got away with it, but the next generation did not. It was the next generation where their faces started to collapse, teeth got crowded, they had temporomandibular joint problems, general health was lower. It was and he was laughed at for this because it didn't follow the rules of genetics at that time. Now, of course, we know that's epigenetics. Genes have to be turned on, and then they're passed on to the next generation where they're more fully expressed. So let's go through just a few examples now of how nutrition, or the lack of it, affects teeth and the oral cavity. Vitamin C deficiency was the first deficiency disease that we learned about a couple of hundred years ago. Scurvy, pretty rare now, but one of my classmates in medical school got scurvy during medical school. That's how much nutrition they taught us. Glossitis, you probably won't see it in a fluoride case like this, but if you do see that smooth red tongue, that's a B3 deficiency. This I see a lot in my practice. I examine every patient I see, they get a general medical examination, and I carefully examine the teeth. And when I see gum recession like that, I know it's folate deficiency. Now, that's important in its own right, but folate has a very important role to play in detoxification. particularly in that genetic group, the MTHFR pleomorphisms. So when I see this, I start thinking MTHFR pleomorphism, they're not going to detoxify well without not just a little B12, B6 folate, but a lot of it. And some of these people, they need 5 grams of folate to get good results. I just mentioned this as a bit of a curiosity. I doubt if many of us are going to diagnose vitamin D deficiency, but interestingly, this group of paleopathologists came across this X-ray way of diagnosing vitamin D deficiency. You'll notice on the right side, it's like a little easy chair, a little chair, and that's a sign of vitamin D deficiency. Dental enamel hypoplasia. Now, we used to think this is fluoride, and maybe some of it is, but it's also an excellent sign of gluten sensitivity. I look carefully. This is a fluoride case, but I look for just little patches of white on the teeth. If I see that, I know they're gluten sensitive. Gluten sensitivity is epidemic right now. 1 out of 3 people are genetically susceptible. Just a matter of the genes being turned on. A couple of generations ago, only a few did. Now, I suspect that most adults who have the genetic potential are gluten sensitive, whether they know it or not. One way you can know is to know how many medications you're taking by the time you're 55. If you're taking 3, 4, 5 medications, chances are you're gluten sensitive. Soft teeth. Now, this is a good example because we get a double whammy here. The gluten-sensitive person gets soft teeth, and at least a generation or 2 ago, got lots of mercury amalgam. Now, gluten sensitivity, the nutritional side of it, the chickens come home to roost in your 30s or 40s when your nutrition starts to really decline. And that's when your mercury levels are going up. And when those lines cross, that's when many people crash. This is the mercury poisoning, the fatigue, depressed people. Very often it's gluten sensitivity going up or toxicity going up, nutrition going down. So dental caries, we've known for a long time vitamin D is critical in good dental health. So is vitamin A. I've mentioned briefly calcium phosphorus ratios. And then activator X, vitamin K2. So vitamin K2 is the new kid on the block in the vitamins. A lot of people don't even know it exists, or they confuse it with vitamin K1. Weston Price knew it was a fat-soluble vitamin essential for teeth and bone development. He took samples of milk from around the world and measured this activator X content, and he found it was richest in grass-fed animals, in their milk, their eggs, and their meat. Now, what vitamin K2 does is tells calcium where to go. So it puts the calcium in the teeth and the bones where it should go, and removes it from the arteries, the tendons, and the kidneys where it shouldn't go. So vitamin K2 is important in both those groups of people, the osteoporotics, people with bad teeth, and the people at risk of coronary disease. In the diet, the richest source is natto, which is a Japanese fermented bean, very high levels. But if you can afford it, foie gras. Start eating it. Duck eggs, rich cheeses. And if you can't afford that stuff, get the vitamin K2 capsules, 1 or 2 a day. Now, in my reviewing nutrition, I consulted Gaby's book on nutritional medicine. If you don't know about it, it's a book about this thick, thousands of references to nutrition as it applies to medicine. Excellent, excellent, interesting book. And I'll just mention, Gaby, after reviewing all the important things for gum disease, this is what his little recipe, and I'm using it in my practice. Coenzyme Q10, 60 milligrams a day. Folic acid mouthwash, 0.1%, a couple of times a day. And then brushing buffered vitamin C, the calcium form powder, gently into the gums every day. Very powerful way of, and non-invasive way of treating periodontal disease. Now, we come to the next part. We've been talking about the general effects of health on the teeth. Now we're going to talk about how teeth affect the general health. Dissemination of focal infection. I'm not going to talk about that because Dr. Levy covered that and Dr. Weston Price had the same kind of data, that it's a greatly underdiagnosed problem, particularly heart, but also kidneys and other organs, focal infection from the teeth. But perhaps more interesting is this business of autoimmune response to dental infection. Now, Weston Price didn't really know about autoimmune disease at that time. Old-timers often would say to people with rheumatoid arthritis, get all your teeth pulled. And a few people did that and got better. But it got out of repute because there were a lot of disappointed patients too. Sorry, before we get into that, just to cover autoimmune disease a little bit, teeth are not the only thing. There are three main factors that relate to autoimmune disease, which, like autism and Alzheimer's, is exploding right now. Vitamin D is probably the easiest and one of the most powerful things to correct when it comes to the risk of autoimmune disease. In fact, it's often called latitude-dependent autoimmune disease. Reason being that in the tropics, vitamin D levels are at their highest, 60 in the American way of measuring them, 150 in the SI units. Seems very high, but they have the lowest autoimmune disease, lowest cancers. As you go north, the vitamin D levels go down and those diseases go up. Another important factor is our friend gluten. We know that the risk of autoimmune disease goes up 10 times with celiac disease, and there are many, many people who don't have celiac disease who are gluten sensitive. So I, for practical purposes, consider all people with autoimmune disease to be gluten sensitive. We know the mechanism. It's mediated by these anti-tissue transglutaminase antibodies, which are produced in the small intestinal wall. The first thing the body does is reacts to gluten and gives you anti-gliadin. Next thing it does is the anti-tissue transglutaminase. And these antibodies are tissue specific. So one will go to the pancreas and cause type 1 diabetes. Another goes to the skin, causes psoriasis. Another goes to the joints, causes rheumatoid arthritis. Those can be measured in a tissue-specific way by Cyrix Labs, by the way. And there's an element of molecular mimicry. There seems to be some mimicry in the tissues and some of the grains we're eating that might be behind that. So let's carry on with autoimmune disease and infection. Now, there's been a suspicion that infection is involved with triggering autoimmune disease for some time. And Yehuda Schoenfeld in Israel, who is probably the world's authority of autoimmune disease, he says, when it comes to autoimmune disease, everything is infectious until proven otherwise. Now, that's important. Because what do we do with autoimmune disease? The first thing we do is try to suppress the immune system with steroids. We don't realize it, but what we're doing is making the disease worse, because it's just encouraging the infection part of it. Now, I'm just going to talk about two of these. Rheumatoid arthritis, because there's some good literature to support the connection. Polymyalgia rheumatica, there's almost nothing in the literature I can find, but it's one I have personal experience with, and I can vouch for there being a very strong connection. If you want to pursue this a little bit, one of the best sources of information is the website of the Arthritis Foundation. And they have been tracking this over the last few years. Everything connecting dental infection with rheumatoid arthritis. And they're publishing some of these reports. Now, there was a rheumatologist back in the 80s who caused a bit of a stir by using minocycline to treat rheumatoid arthritis. The results were a bit mixed. Some people have carried on with this, but it hasn't become mainstream. However, it's probably one where if you get it early enough, you have a better chance of success. Now, in the last 5-10 years, there's more and more research showing that there's a strong association between gum disease and rheumatoid arthritis. And one of the more exciting papers that I read recently is that moderate to severe rheumatoid arthritis benefits with thorough gum cleaning. Isn't that great? So your rheumatoid patients, get your hygienist in there and thoroughly clean them, because these patients get results very quickly with that. Now, polymyalgia rheumatica, I've kind of stumbled across this, and over the last 15 years, I think I've had about 12 cases. Every one of them had dental infections, and every one of them except one responded to treatment of the dental infections, and they had a complete cure. Okay? Now, polymyalgia rheumatica does tend to go away by itself over a couple of years. But these ones, in fact, I had one quite recently, they get a complete cure. They can get off their steroids if they're on them, and they don't get a recurrence as long as their teeth are kept healthy. The one who I failed with had a parotid gland infection as well. This lady, you can see how swollen her gums were. She presented with giant cell arteritis, and she lost the upper half of her visual field in a matter of a day or two. But cleaning up her teeth, and there was a lot of work, within a year she was cured of that. Now, here we're talking about bringing coals to Newcastle, systemic effects of dental materials. I'm not going to touch this. This is this is what everybody else has been talking about. I just want to acknowledge, I feel it's very important too. I'm not going to touch it, but I am going to self-indulge here a bit in that I have been treating mercury toxicity for 25 years. I published a paper on it, and I find it was a big part of my practice. Less so now, because I think there are fewer and fewer people who have mouths full of fillings. But my clinical experience would say that one of the most important things is individualizing the patient's detox needs. There's no shotgun method for detoxing everyone. People vary tremendously. Some people, the critical thing is getting enough zinc and B6 into the systems. Some it's the B vitamins and folate. Some it's hydration. They need to be, some it's diet. So I spent a lot of time trying to identify where their weak spots, why did they get into trouble with mercury when so-and-so, he's 95 years old, has a mouthful of black, he drinks a bottle of whiskey a day, and he's fine. Your patient got sick because of something. It's not just the mercury. There's something that went wrong. Another thing I learned fairly early on is to be careful with chelators. Chelators, I've used DMPS mostly. It has a place. It has in fact, it's an excellent way of detoxifying, but you need to be careful, and I never use chelators until I'm satisfied that my patient's physiological detoxification is working well first, and I'll often wait a few months for that. Hydration, very often overlooked, and hydration is not just water, it's also salt and other minerals. Extracellular minerals are extremely important. And I always like to make sure the liver and the kidneys are looked after. I use neural therapy to keep those organs happy when they're detoxifying, but you could use homeopathics or other general methods. And I feel that adequate protein in the diet is extremely important. Vegetarians get into real trouble if they have a lot of mercury on board. Okay, here another way that dentistry can affect our general health is by irritation of the nervous system and the energetic system. By irritation, in neural therapy we use the word interference fields. It's an irritation that can cause just a local reaction, or it can spread through a whole segment, or up half the body, or involve the whole body. Typically, in dentistry, the irritations are focal infections, and they very often are silent, so you have to look for them. They can be in an extraction scar. They can be from a mechanical irritation, from a prosthesis or perhaps a bad bite, and they can be from mixed metals causing electrogalvanism. So they can disturb the body in two ways. One is through the energetic system, the acupuncture meridia, and the other is a reflex action through the nervous system. Now, does everyone know the Voll charts, the acupuncture meridia? And not too many? Okay, you need to get this. I have a chart on my examining room wall. Now, I know the print is too small for you to see, so I'm hoping you might be able to see a little bit from this. But what it shows is each tooth sits on acupuncture meridia. And there are connections between that tooth and the organs and structures on it. So, for example, the wisdom tooth, if it's an upper wisdom tooth, it's connected with a pituitary gland, internal ear. Every once in a while, you're going to find a unilateral tinnitus, and it's from a wisdom tooth or a wisdom tooth scar. It also goes through the heart, and you'll see some people with unexplained palpitations or arrhythmias. It's a wisdom tooth. And it goes through the small intestines, so unexplained diarrhea. It's not common, but it does happen. And the other big one in musculoskeletal medicine is the sacroiliac joint. Similarly, down the middle goes the teeth, goes right down the middle of the body, reproductive organs. So if you go to one of the high-class German or Swiss cancer clinics with your cancer, on the first day, they're going to x-ray all your teeth. And if you have a root canal in a tooth that's on the meridian of the cancer, that tooth is going to go on the first day. They don't wait around. And I actually have a few cases where I've seen cancers go in remission when a root canal in a critical tooth is removed. This fellow had a very unstable back. He'd had the best of chiropractic and osteopathy and prolotherapy and so on and so forth, until we found an interference field in his wisdom tooth space. And you can see the tooth is gone, but he had had instability ever since that tooth was extracted 20 years before. Injection of procaine into that scar corrected his joint instability. This man had an intractable shoulder bursitis. Fix the tooth, fix the shoulder. Now, this I'll go through very briefly. Trigeminal nerve, the dentist's friend or enemy. We had a wonderful lecture on that yesterday. But you'll notice with that middle branch of the trigeminal nerve, see that sphenopalatine ganglion? What it does is it provides feedback. So it sends signals to all the places where the trigeminal nerve is picking up sensory information. This becomes involved with facial pain and a lot of unexplained dental pain. The sphenopalatine nerve ganglion is involved. And it's partly because of teeth, but it's also because it can be affected with chronic sinus inflammation, old trauma, TMJ dysfunction, and if there's a lot of mercury in the tissues, the sphenopalatine ganglion can become irritated. This lady had facial pain, and you'll notice the redness at the gingival margin of the bicuspids. That went away when the sphenopalatine ganglion was corrected. So did the facial pain. But that just shows you the hyperemic response of the sphenopalatine ganglion to irritation of the trigeminal nerve. I'm getting a little behind here. So similar symptom principles in the lower jaw with the submandibular ganglion, unexplained dental pain, look at the submandibular ganglion. Okay, now we're going to get to let's say osteopathy, musculoskeletal influences on dentistry. This part here, well, let's go straight to it. Again, unexplained pain can come from the musculoskeletal system. These are pictures from Travell's book. And if you don't already know these, I'd recommend getting pictures of these and sticking them on the wall. So, masseter gland, masseter muscle, trigger points as shown here. Temporalis muscle, same sort of thing. And the anterior digastricus muscle, trigger point, lower incisors. So, if you have some unexplained pain in these teeth, it's worth thinking about this. Now, craniosacral motion, this is a very big and complicated field. So I go into this a little bit reluctantly, but we had such an excellent lecture on temporomandibular joint dysfunction yesterday that I want to throw this in the mix just to stir things up a bit, perhaps. How many of you here are familiar with craniosacral motion and cranial osteopathy? Not everyone. Okay, so briefly, this is something that's not taught in medical schools in the English-speaking world, but it is in the Spanish-speaking world and the Mediterranean medical schools. We are taught that the bones of the skull fuse at age 7 or so. There's no motion after that. It's not true. The skull actually moves. It's a very slow, rhythmic movement. Slower than the breathing movement. In one phase, the one on the left, is extension where the skull narrows and lengthens. The other phase is flexion on the right where it broadens and foreshortens. And at the same time, all the bones of the skull move in synchrony. You'll notice in the sutures there's little interdigitations, and think of those as gears in a clock, because that's exactly what they are. As the temporal bone rocks back and forth, the parietal bone has to go in the opposite direction. The sphenoid has to move to accommodate that, and so does the occipital bone. So there's this intricate movement, rocking back and forth. Roughly, this would be the extension movement, where the head is narrowing. But you'll see, what does this do to temporomandibular joint dysfunction or function? And in fact, the whole bite mechanism. You can see if the temporal bone is rotated and stuck there, that's going to disturb the whole bite mechanism. So this is a critical thing. I think anybody, before they get into any kind of important teeth, jaw reconstruction, needs to be assessed by a good cranial osteopath to make sure things are sitting nicely before we start changing the teeth and the bite. Now, there's another area from mechanics that applies to dental bite and so on, and it's the principle of tensegrity. Now, tensegrity is an idea that came out of architecture, Buckminster Fuller, back in the 50s with the geodesic domes. He showed how you could build these massive big structures without any pillars. And he used a method of distributing tension throughout this whole big sphere to make these buildings possible. And I remember in Montreal in 1967 with Expo, they had these big spheres and they were a source of amazement. Anyway, in the late 70s, early 80s, a friend and colleague of mine, Stephen Levin, who's an orthopedic surgeon, began to see there might be an application to this in body mechanics. And to make a long story short, he realized that all living structures are held together by tensegrity. It's not levers and pulleys, it's tensegrity that allows the complex movements that we have and the tremendous forces that the body can withstand. At that time in the early 80s, it was a great mystery how lumbar discs were able to withstand a weightlifter lifting a few hundred pounds. But when you apply tensegrity to it, it starts to make sense. Now, with tensegrity, what's happening is tension is distributed throughout the whole body, or sometimes within the body in a certain area, but it's a distribution of tension. And it will, if you have a tight body, for example, if you have a tight diaphragm, it'll spread tension through the whole body. Everything's going to be affected. Craniosacral motion, limbs will tighten up, and so on. And where the problem is going to surface is the weakest spot. So if there's an area where there's a history of pain, that's where it's going to show. So when I'm treating a patient manually, say a patient coming in with headache, and I'm treating their diaphragm, I explain to them that we're trying to free up their whole body, and often that is the solution to their headaches. Similarly, if they've had a head injury and there's tension in the head, that may be why their back is unstable all the time. So this would apply as well to the jaw mechanism. So if you have, again, a very tense body, you have much less room to play around with when you're trying to correct a bite. Whereas if the body's more flexible, there's more room to play with there. I'll say a little bit more about that in the few more minutes I have left. Okay, so we yesterday again in the lectures we had examples of reflex disturbances of musculoskeletal mechanics from a TMJ syndrome. The young lady who was having problems in the wrist and neck and so on from problems in the bite. We can also disturb things, as I mentioned before, through the acupuncture meridian. Now, one of the areas that is most affected by disturbed dental mechanics is the upper cervical region. This is an area very richly innervated. There's 40 times as many proprioceptors per cubic inch of flesh as there is in the gastrocnemius muscles. It's also extremely important in keeping our posture and our balance, but it's also very, very sensitive to neurological inputs from our teeth, especially the wisdom teeth. Now, there's a whole school of chiropractic called the upper cervical chiropractic, where they concentrate on the upper neck. They treat everything in those upper 2 or 3 vertebrae, and they claim they can treat anything with it. And this comes from their literature, and this is not something to be sneered at. They do get some very good results. And there are explanations how this may occur. This is a picture from the Dvorak brothers' book where they were tracing muscle tension in response to irritation at different segmental levels. So this particular picture was an irritation at the occiput, and these were all the muscles that were affected by that. Now, what the upper cervical chiropractors won't admit or recognize is it can go the other way. So here's a patient who had an L5 problem, and these are the muscles that goes right up to the neck. So it's not a one-way thing. Now, I mention this because very small changes in bite can have very large effects everywhere in the body. And I bring up the question, is it possible to go too far in correcting a bite? I'm not saying too far you can't do a really good job, but is it necessary to get as much precision as we aim for? And I'm going to, this is your field, not mine, so I don't want to step on anybody's toes here. But I'm going to use an example from the low back. It's been known for many decades that a quarter-inch difference in leg length, your incidence of backache goes up a lot. So there are osteopaths and chiropractors who pay a lot of attention to this, and the way you do it is you do standing x-rays. It requires special training of your technician, special leveling of the buckies and so on. And then you take these x-rays and you measure them very precisely to, and then prescribe a lift to raise 1 foot. And it can be very effective. But the problem is that these people are stuck with that for a lifetime. They will have to wear a lift in every shoe for the rest of their lives. Going barefoot, their body's going to complain about it, and it's a lifelong commitment. I did quite a bit of this back in the 80s when I discovered this, but after a while I found you didn't really have to do that. As my manual skills improved and I was able to release those tight areas, improve the general physiology, get some magnesium in their systems and so on, their bodies became more flexible and they were not as sensitive to that little difference. Okay? So I just throw that out. If this is true of leveling the low back, maybe it applies to the jaw as well. Maybe we need to pay more attention to making sure the muscles are flexible, enough magnesium, getting rid of food sensitivities, things that tighten up the body, and so on. And I'm closing with this one picture. It's a 16th century picture, and I think it's such a beautiful, beautiful picture of demonstrating the interconnectedness of the muscular system. You know, the balance is just so perfect. Now, it doesn't show the jaw muscles, but I think the idea, you can see that it wouldn't take much disturbance in any of those muscles to throw the whole thing off. So, bring it all together. I just wanted to sort of bring together these medical, dental, and osteopathic realms and how they interact, and just plant the seed that, and maybe I don't need to, maybe you all know this already, maybe I'm just reminding you, understanding these connections yields rich diagnostic and therapeutic wards. So, thank you.